We are live now, doctor.
Thank you. So, good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today. It gives me immense pleasure to welcome you all for the 11th master class of the online PG teaching program, Kaksha. Kaksha is a PG teaching program envisioned by ROS, which will cover all the major topics of postgraduate training over the next 2 years. We'll be bringing the best of national and state faculty experts to share their knowledge and interact with you. The residents are also encouraged to put forward their doubts in a fearless manner to all the faculty present and the panelists. Coming to this class, we have today with us my dear friend, Dr. Vardhaman Kankariya from Asian Eye Hospital, Pune, who will be thread-bearing a major and important topic, not just for PGs, but for every practicing ophthalmologist. That is refractive surgery. Dr. Vardhaman is an authority and a very well-known figure amongst the cataract and refractive circles, not just in India, but around the globe, and will be introduced in detail by Dr. Harshul Tak, who is our panelist for today's Kaksha. Harshul sir needs no interaction. He is one of the most prominent national faculty in the field of cataract and refractive surgery today. I welcome the ROS Executive, President Khilnani sir, President-elect sir, Dr. Sanjeev Desai, and our Dynamic Secretary, Dr. Ghulam Ali, for today's class. There are two hot seat residents today, Sangam and Pushkar. All are final year postgraduate students from different colleges in Rajasthan, and they are encouraged to interact with the speaker informally. There'll be a grand quiz with exciting prizes at the end of the Kaksha. So keep a strong vigil and listen carefully. Over to Dr. Harshul sir to carry forward the Kaksha and introduce Dr. Vardhaman.
Yeah, hi. So thank you very much, Vishal, for initiating this amazing Kaksha series under ROS banner. A warm good evening to all of you, all the residents there, and a warm welcome to my dear friend, my younger brother, Dr. Vardhaman Kankariya from Pune. So let me give you his brief introduction, because if I give his full introduction, so Kaksha will be over by the time I finish his introduction. So Dr. Vardhaman is right now Chairman Scientific Committee of Maharashtra Ophthalmic Society, and is also former Secretary of Maharashtra Ophthalmic Society. He is Director of Asian Eye Hospital in Pune, and he completed his medical school from KM Hospital, earning gold medal. So he has gold medal wherever he goes. So he had gold medal in MS Ophthalmology. Then in Shankar Nethralaya, he finished his residency. And after that, he became one of the first and only Indian ophthalmologists to undergo structured one-year fellowship in advanced refractive surgery in University of Greece under guidance of father of LASIK surgery, Dr. Professor Phakic. And he's one of the most experienced refractive surgeon globally for his age. He has done more than 35,000 refractive procedures till now and has delivered over 250 international and national faculty lectures. And he has won numerous gold medal and awards in various societies, national and international. So I think with this, without further wasting any time, let's give again a warm welcome to Dr. Vardhaman Kankariya and hear from him about refractive surgery. Dr. Vardhaman. Yeah.
Thank you so much. So at the outset, I would like to thank from the bottom of my heart my elder brother, Dr. Harshul. We have been close friends for more than now 10-15 years. And it's always very exciting to be back to Rajasthan. I have been part of many amazing conferences that he has organized in the past. And the warmth that the Rajasthan Ophthalmic Society brings along with it is really amazing. I really love being amongst all my friends in Rajasthan, thanks to Dr. Harshul. And again, thanks to Dr. Vishal. We go back right to Shankar Nethralaya days, where we were together. And it's amazing to see that he is doing amazing work as the scientific committee chairperson of ROS as well. Also, thanks to the Dr. President, sir, and Secretary of Rajasthan Ophthalmic Society. And friends, all my younger friends and dear colleagues, I'm going to take you through some of the, let's say we are going to threadbare the technological aspects which have happened in refractive surgery over the last many decades. And we will discuss, of course, in details what is the current nature of refractive surgery, especially for postgraduates and our young ophthalmologists. I have kept this presentation very basic so that you understand what exactly is refractive surgery, what are the different technologies, how they have evolved, what are the different technologies' benefits, what are the drawbacks, and in which condition, how we choose which surgery we are going to choose for our patients. I have been in refractive surgeries for last almost 13 to 14 years. This is a specialty of my interest, and with all the experience that I've had so far, I'll try to make it easy for you. So friends, we all know that refractive surgery is a dream realized today. These are the surgeries to eliminate or decrease dependency on glasses or contact lenses. As of today, the refractive surgeries have come to a space-aged dream of a 5-minute, no patch, laser only, bladeless, flapless, with very quick recovery and a great amount of wow effect with the current advancements. But as the Greek philosopher Aristotle says, if you would like to understand anything, you have to observe its beginning and its development. So friends, it was almost 1 century back. It was in 1920 when the primitive refractive surgery was started in Japan by Professor Sato. So what Professor Sato tried to do was, whenever he saw a patient who had keratoconus, he performed a posterior RK. Yes, you are hearing me right. This is called as a posterior RK because he used to enter the antechamber with a blade. He used to cut on the endothelium, and as we know that after hydrops, the cornea becomes flat, and then he used to actually think this is a kind of treatment for keratoconus, and this was the real beginning of posterior RK, thus the real beginning of very, very primitive and crude refractive surgical procedure in 1920s. But from that time to almost a century now, we have come to an era in which we have seen amazing different innovations which have actually come over time. Some of them stood the test of time, but many of them actually faded away. And it is thanks to many innovators, as you can see on this slide. Professor Palicaris, who invented LASIK surgery, Professor Fedro, who refined the RK procedure. Most importantly is, of course, Dr. Barake, who is known as the father of refractive surgery, and Professor Palicaris, who is known as the father of modern refractive surgery. So this is a very interesting story. When Professor Fedro actually received a boy in his clinic, this boy had he fall from his bicycle, and he was wearing glasses. So when he had a fall, those glass pieces actually broke, and those glass pieces actually got introduced into the cornea. And this patient, when he was brought to Professor Fedro did a small procedure, removed the glass pieces from the cornea. But when he saw this patient on follow-ups, he actually saw that the patient's myopia, his myopia, has started to reduce. And he was very surprised to see that the cornea had actually started to become flatter. And this was his inspiration to start radial keratotomy with very refined and nomogram-induced procedure, in which by using diamond knives, he started to perform small cuts in the periphery of the cornea, which bulged the peripheral part and flattened the center indirectly and reduced the myopia. This used to work fairly for low myopia in 1970s and in 1980s. However, this procedure started to showcase certain complications intraoperatively. And of course, there was a very large scale study which was done in the US by Dr. George Waring, and that study is called as PERC, Progressive Evaluation of Radial Keratotomy. And that PERC study demonstrated many disadvantages of RK, therefore it went out of vogue. After RK, the next procedure which actually came was called as ALK, in which there was an automated lamellar cut. First, a microkeratome was put to cut a corneal flap. And then after that, the same microkeratome was mounted onto the cornea with a flap actually unfolded. When another slice of the corneal lenticule was created with mechanical microkeratome, and it was peeled off. You can imagine that this is doing almost like crude way of doing smile with a flap with mechanical microkeratome in those times. And this is what was called as ALK procedure in 1980s. However, both these procedures lacked precision. It definitely lacked reproducibility and lacked efficacy of treating this refractive errors with a great amount of safety. And therefore, these surgeries actually required replacement. The golden era of refractive surgery started with the Excimer lasers. The Excimer laser was first invented by an American physicist of Indian origin. His name is Dr. Manilal Bhaumik. Dr. Manilal Bhaumik, while working in the US, actually invented first active Excimer laser. However, after some time, this Excimer laser was actually being used on the chips of the computers. So these chips were etched because of very precise ablation, which was done with the Excimer lasers during those times. So Dr. Srinivasan, as you can see, the person on the right side, was in those times working with IBM, and he actually forethought that if this is such a precise tool, we can probably use it on also living tissue. And first, he proved his concept of accuracy of this Excimer laser with very minimal collateral damage on the living tissue on his own hair. So as you can see, this is the photograph which demonstrates the electron microscopy of his own hair, which for the first time demonstrated that there was a UV photo etching of the organic matter possible with Excimer laser. So this is basically now called as photoablation procedure. Thereafter, Rangasamy Srinivasan contacted Dr. Steve Trochel. As you can see in this photograph on the left side, I have had good fortune of spending some time also along with him, with my mentor, Professor Palikaris. Steve Trochel was working in the UK, and he was actually the first ophthalmologist who proposed applying this Excimer laser to reshape the corneal tissue precisely by using the principle of photoablation. And the first refractive surgery which actually came into vogue by using the Excimer lasers, very precise photoablation, was called as PRK. The first PRK procedure was performed by Professor Theo Zeiler, and then this was again done in the US on a sighted eye by Dr. Margaret MacDonald. The PRK, because of the basically safety and the reproducibility of these Excimer lasers, became the first versatile treatment for myopia, hyperopia, and astigmatism. It demonstrated amazing amount of precision and safety and became FDA approved in 1996. However, this PRK procedure had certain drawbacks because this had painful post-operative course, was developing corneal haze, and showing significant amount of regression, especially in those times, especially in patients who were unsuitable due to high refractive error corrections. And this drawback was because of the epithelial defect and because the ablation was performed on the surface, that is on the Bowman layer and anterior stroma, where the stromal keratocytes are very active. Thereafter, Professor Ioannis Palikaris, my mentor, he invented and performed the world's first laser in situ keratomileusis procedure, which is called as LASIK. So Professor Ioannis Palikaris fired the corneal stroma after raising the corneal flap by an instrument which was called as mechanical microkeratome. So this is a very historic video because this is the world's first LASIK surgery done on the human eye in the University of Crete on a Greek female. As you can see, this is the mechanical microkeratome. It looks very crude, but this mechanical microkeratome was almost made in-house by the team of physicists who was working with Professor Palikaris. And as you can see, this is done in 1989 to 1990. This is a very small flap with a very large hinge. And after the flap was raised, he used one of the first generations of Excimer lasers to showcase that you can reshape the cornea very well. After that, the flap was put back in its place. And he actually demonstrated that you do not need sutures for the flap to remain in its place, because the flap remains in its place because of the endothelium. Corneal endothelium sucks the flap in and keeps it there. So he blended the flap with the PRK procedure, and this was the invention of LASIK. LASIK had several advantages over PRK in the form of relatively quick procedure with virtually pain-free outcomes, highly accurate even for wide range of refractive errors, and most importantly, giving rise to amazing amount of wow effect. Still today, LASIK still remains as the most commonly performed refractive surgery around the world, and more than 41 million procedures have been performed globally till today. This is currently also the most commonly performed elective surgical procedure on the entire human body. So as the science evolves, as we know, the procedures are known to become more safer. So when the LASIK was invented, there was an advancement further on in both the flap creation with mechanical microkeratome as well as with the laser-based keratomes called as femtosecond lasers. First, let's talk about the mechanical microkeratomes. Mechanical microkeratomes works on the principle of Carpenter's principle, in which when you put the ring in and if you increase the intraocular pressure of the eye, the cornea becomes stiffened and cannot move away from the blade. Thereafter, there is a mechanical keratome head which has applanation plate which goes in front and applanates the cornea, and there is an oscillating blade which comes just behind it and cuts the flap very precisely. As you can see, once the flap is created, it can be raised very well, and the current generation of this mechanical microkeratomes are actually able to give rise to excellent outcomes. There has been also advancements in mechanical microkeratome over time. This is an excellent device in the hands of experienced LASIK surgeon and creates a good flap almost every time. However, it is seen that mechanical microkeratome has certain amount of unpredictability in terms of thickness. And more importantly is that it has high dependency on keratometry. That means that if you have a very flat preoperative cornea, the mechanical microkeratomes can give rise to something called as a free cap, in which you do not have a hinge to the flap. So you can have a free cap, or you may have what is called as a buttonhole if you have a very steep cornea. Buttonhole means, my friends, that there is a hole in the Bowman's layer while you are cutting the flap. That is basically because mechanical microkeratomes creates a meniscus shaped flap. That means it is thinner in the center and thicker in the periphery. And if it is very steep, these are the possibilities of complications. Therefore, the emergence of femtosecond laser as a flap maker actually changed the game in refractive surgery. The femtosecond lasers, they work on the principle of photo disruption as against photoablation, which is used in Excimer. These are the lasers which work with the infrared 1065 nanometers of range. And as we know also the ND-YAG, which is another laser which works in the principle of photo disruption, the femtosecond lasers has 1000 times less collateral damage. So that tells you what is the precision of these lasers. When you're using femtosecond lasers, ultra-short infrared laser pulses are precisely focused inside the corneal tissue. And when you actually put these pulses back to back, you can create a cut of any shape and any size, especially when you're creating a flap. So this is a small animation which is actually showing you how a procedure is done. This is called as a docking. Docking means that the cornea is actually held in place with suction and there is a applanation. Thereafter, the laser is actually being focused and being applied. Millions of these pulses are being applied in a very short duration of time, ranging between 16 to 20 seconds. And once you have the side cut, which is also performed, after this, the flap is raised. And once the flap is raised, you have more Excimer laser ablation done onto the corneal stroma for correction, and you put the flap back in its place, similar to the LASIK procedure. There have been different platforms which are available today to create a flap. The one that I use is from Carl Zeiss, the Visumax. These femtosecond laser flaps have certain advantages over the mechanical microkeratome flaps, and the first and the foremost that they are more precise in its thickness. The femtosecond laser flaps are actually showcase the flap reproducibility of plus minus 5 microns as against plus minus 24 microns seen by studies by MK. These are also independent of keratometry. That means that if you have a very flat cornea or if you have a very steep cornea, the femtosecond laser will always create a very precise and very good flap. As you can see here, this is a live demonstration of how a femtosecond laser works. On the left side, you have seen that mechanical microkeratome has created a mechanical cut, but on the right side, you can see a laser cut is being done onto the cornea. Once it is done, then you have to lift the flap, and as against the blade cut, in this case, you have to do a small amount of dissection because there are going to be some uncut stromal bridges where the femtosecond laser has not cut it, but it is very easy to dissect it off, as you can see. And once the flap is raised, you can actually do your laser ablation very swiftly and then put the flap back in its place. Second advantage is that the femtosecond lasers, you can completely customize the flap. You can customize the flap thickness, diameter, hinge position, and its weight. Comes handy in many situations. I spoke to you about the issue with the mechanical microkeratome flap shape. As against mechanical microkeratome, which creates a meniscus shaped flap, the femtosecond laser creates a planar flap. Therefore, it does not induce any higher order aberrations. And the periphery of the cut of the flap in the femtosecond laser is actually very, very customized, and you can actually have an excellent fit. Because you can have an excellent fit of the flap, you reduce the chance of having what is called as epithelial ingrowth. Epithelial ingrowth are surrounding epithelial cells of the cornea, which can grow into the interface of the flap. You may have also flap sleepage, or you also reduce the chance of flap sleepage or flap displacement in femtosecond lasers, and also reduce the chance of microstriae as well. I've had a good fortune of performing a large-scale study in which we performed a scanning electron microscopic comparison of the stromal bed quality of LASIK flap made by mechanical microkeratome versus two different femtosecond lasers. And we have published this in British Journal of Ophthalmology, in which we have demonstrated that the stromal bed quality was much smoother with the femtosecond laser as compared to the mechanical microkeratome flap. And this is a psychological benefit to the patient because it does not have the fear of blade cutting the cornea. However, although there are so many advantages of femtosecond laser, then the limitations of the femtosecond laser became a hot topic. And one of the most important, of course, limitation is that because wherever there is a flap, you may still have a potential flap displacement anytime, sometimes even 20 years after the LASIK surgery. And of course, there can be other issues such as microstriae, epithelial ingrowth, dry eye, so forth, so on and so forth. So as Thomas Edison says, there is always a better way to do it, and we have to find it. The relaxed smile surgery, which is the natural third generation laser that is available now, which is the procedure of choice for me since almost a decade, since 2014, from the time we introduced it in Pune. The relaxed smile is a bladeless as well as a flapless variation of the corneal refractive surgery. As you can see in this animation, we are using a 3D laser from the Visumax Carl Zeiss, in which there is a lenticule which is being created with the help of the laser. You first create the posterior cut of the lenticule, then you create the anterior cut of the lenticule. When the circular lenticule is created with the help of a side cut, you create a very small 3 mm axis cut, which is also called a smile cut, and remove this lenticule after dissection in one piece. And this refractive lenticular procedure in intact cornea without creation of the flap is what is the beauty of the relaxed smile surgery. So just to show you how the relaxed smile actually looks like, this is the laser delivery which is being done. This is the posterior cut. This is going to be followed by what is called as a side cut of the lenticule. And after that, we are actually, there is going to be performance of the anterior cut. Once the anterior cut, which is called as the cap cut, is performed, then there is a 2 to 3 mm side cut of the smile lenticule. Once that is being done, you just go ahead and you have to enter. It is very important that you actually find the right planes. The dissection of the smile has a bit of learning curve, but it is not that difficult. So first you go in and you find the anterior layer of or anterior interface of your lenticule. Then you have to go on the other side and find the posterior interface of the lenticule. Once you're sure that you have actually found both the surfaces, first you have to dissect the anterior interface. Once the anterior interface is dissected well, if your energy optimization of the laser is very good, it is very easy to dissect it out. And then you go back and then you actually dissect the posterior lenticule. Once you have done the entire dissection of the posterior lenticule, you have to leave behind a very small bridge at 3 and 9 o'clock that you can keep just so that you can have very easy dissection without having the issue of this lenticule sleeping over one or the other side. And once those are also cleaved, you have to go back with a small forceps and remove lenticule in one piece. So as you know, without creation of the flap, we have created a very, very beautiful refractive outcome. So this smile demonstrated several advantages over now femtosecond LASIK. First, of course, there is no flap to get displaced. There are no microstriae, and the chances of epithelial ingrowth reduced very, very drastically. There is better centration because in smile, the centration of the treatment is on the visual axis, as against with the femtosecond LASIK, it is actually on the pupillary center. Therefore, the studies have actually shown that it is definitely better to have the centration over the visual axis as against the pupillary center, and this gives rise to much better quality of vision overall. It is not only the centration of the treatment which is better in SMILE, but it is also the extent of the treatment. As you can see in the photograph which is given below, in LASIK, you will see that the periphery of this LASIK ablation seems very amoeboid. As against that, if you see at SMILE, you will see that it is a very wide and very regular peripheral extension of the ablation. There is also less induction of spherical aberrations because SMILE lenticules are aspheric. And as against LASIK, in LASIK, when you cut a flap, there is a bit of peripheral expansion of the collagen fibers, which does not occur with SMILE. There has been also a lot of studies and published data about visual outcomes after SMILE versus Femtosecond LASIK, although they have shown more or less similar outcomes, but the spherical aberrations are induced much lesser in SMILE. That has been the general consensus. I think the most important advantage of SMILE, in my opinion, current generation, is that we see a lot of patients who are actually computer users, and many of them have pre-existing dry eye. So if you actually look at the way the SMILE is performed, intuitively, you will understand that SMILE spares more epithelial, subepithelial nerve plexus. So just to give you this example, you can see in the photograph, which is upwards, that there is a subepithelial nerve plexus, which is the major sensation of the cornea. And when you cut a flap of the cornea with LASIK surgery, you are actually cutting the corneal subepithelial nerve plexus, and on the top of that, you are doing the ablation with the Excimer laser, denuding more and more subepithelial nerve plexus cells. As against in SMILE, you can actually go slightly deeper. Because you can go slightly deeper, you can actually try to preserve the subepithelial nerve plexus in much better way as compared to the LASIK procedure. Therefore, there have been studies. Now, this is a very good study published by Diane Reinstein, which is one of the major proponents of SMILE in the world today. And he has compared 16 LASIK studies versus 9 studies done for SMILE, in which he has showcased that when it comes to corneal sensation, in LASIK, the corneal sensation drops to 10% immediately after surgery and improves very slowly. As against in SMILE, it reduces to only 50% and improves much faster. Therefore, there is less corneal neuropathy and much better preservation of the corneal nerves. This has also been seen by confocal microscopy. As you can see, this subbasal nerve plexus at 1 month in SMILE seems to be much better preserved as compared to the LASIK in this study, which is published from Japan, from Kimiya Shimizu. There have been also studies which have been done for both objective as well as the subjective parameters of dry eye, because it was hypothesized that dry eye should be lesser with SMILE, and this has been proven. Now, both objective as well as the subjective parameters of dry eye are significantly less in SMILE as compared to the LASIK procedures. There is one postulation which I don't agree with yet. This is basically theoretically, as we all know, when it comes to the biomechanical strength of the cornea, the anterior 1/3 is known to give rise to maximum biomechanical strength as against the posterior 2/3. So in LASIK, it is presumed that you are actually cutting the flap and then denuding the subepithelium or the anterior stroma much more as compared to the SMILE, because in SMILE, you are actually retaining the cap. Presumably, the SMILE should retain the biomechanical strength much better, but unfortunately, that's not the case. In SMILE, it has been seen now, I think, by many studies that the biomechanics are actually almost similar to LASIK surgery. Therefore, whenever you choose a patient to undergo a corneal laser surgery, your selection criteria for LASIK and SMILE should be exactly the same. Do not discount and do not perform surgeries on patients who are having extremely thin corneas or who are keratoconus suspect with SMILE, because that will induce ectasia. There are other benefits of SMILE because it has no stromal exposure. There is no need of interface irrigation in many patients. There is less possibility of having DLK and infections. It is a much faster single step and single laser procedure. Takes practically 5 to 7 minutes for both the eyes together, as against with Femtosecond, it takes 10 to 15 minutes. And this lenticule, friends, that we are removing, we can use this lenticule also for intrastromal implantation for hyperopia treatment or keratoconus treatment as well. We did a small study in Asian Eye Hospital in which we did a contralateral study of randomized eyes. One between LASIK and one eye was actually matched for SMILE. When we performed these surgeries for patients who had moderate myopia, we actually demonstrated that the vision with of them were actually statistically significant, but SMILE was actually showing small amount of superiority. When it comes to corneal aberrations, SMILE retained much better corneal optical quality, and the corneal sensations again with SMILE were preserved much better at 1 month, but after 6 months they were actually almost similar. When it comes to the dry eye parameters, both objective as well as the subjective parameters of the dry eye, which are OSDI score on questionnaire, your TBUT time, Shermer score, and dry eye severity score, all of them were significantly more deranged with the femtosecond LASIK as compared to the SMILE surgery. And it improved much faster with the SMILE than with the femtosecond laser surgery in itself. So from the era of RK to go to PRK, ALK, PRK, LASIK, femtosecond, LASIK, and SMILE, we have come to a situation now where SMILE has actually married the benefits of PRK and LASIK both, in which you have let's say much better stability, no flap creation as in PRK, and much faster recovery and no pain and no haze as we see in LASIK together in the form of SMILE. So from the RK, which was a very primitive procedure, to come to the current beautiful butterfly, which is SMILE, we have truly come a long way. So SMILE is generally done for very regular procedures. People don't perform SMILE for very high astigmatisms. I'm also reluctant to perform SMILE for anybody who has more than -2 cylinders. I use Contura or topoguided femtolasic for them. But for some patients who are in contact sports, for example, where you cannot create a flap, you can still perform a SMILE by doing what is called as a mechanical cyclotorsion compensation. So in this case, as you can see, I have actually marked the 0180, and then I have actually rotate the graticule to mechanically orient the SMILE to compensate for cyclotorsion. And with this case, we have seen that we can give rise to very good outcomes, even with the SMILE procedure. The SMILE also comes handy wherever you have patients who have extreme amount of contact lens wear and have some amount of dry and peripheral vascularization. Especially, you don't want to create a big flap in them. So in this case, as you can see, I have created actually a very small temporal side cut, not the superior one, because there was a lot of superior neovascularization and the patient did very well and without inducing a significant amount of dry eye. This is a very unique case that we have performed for SMILE after the patient had undergone PRK in MP at the age of only 12 years. So he had a progressive myopia and came to us with a moderate myopia now. And after undergoing PRK for enhancement, we have used SMILE. This is the first such case in the world. And we have published this case in IGO 2 years back, where we have showcased that in a follow-up of up to 5 years, that the SMILE demonstrated very, very stable outcomes for this patient who underwent PRK primarily and showcased residual errors. SMILE also has its own complications. I'm not going into the details of them, but one of them I'm just going to showcase where we used a novel technique to overcome it. This is called a suction loss, friends. So basically, as you can see, before the entire ablation was performed, we lost the suction and the side cut could not be created. So the lenticule was created, but we could not create the side cut. So the concern was to gain access to the formed lenticule. Of course, in this case, you can also convert this into a flap, or you can do a surface ablation, but we wanted to give him or give the patient the full benefit of SMILE surgery of being flapless. So we used what is called as Circle software. So Circle software is a specialized software which actually converts your SMILE lenticule into a flap, but we tweaked the parameters of Circle software in which instead of creating the flap cut, we actually created only a small incision with the Circle software. And this became actually world's first such case in which the Circle software was used in a novel way to create only a small incision to manage this suction loss. As you can see, we could actually create this small incision very well, and I'm dissecting the lenticule in one piece, and once it is removed, then we are through with the procedure. So this patient performed very well and did excellent post-operatively on day one was 6/6, and we published this case also in JCRS recently. So friends, when it comes to the corneal laser surgeries, in 1990s and early 2000s, there was actually no limit. In fact, we have been personally, my family has been in refractive surgery for last 37, 38 years now. We started in 1985. So because there was no limit, we had done patients in early 1990s of also who were in their late 12, 13, 14, 15 diopters. But slowly around the world, it came in vogue that if you do a laser procedure for somebody for such a high number, you are making the cornea too oblate. There is a loss of quality. There was induction of spherical aberrations, a lot of halos and glare for the patients, less amount of residual bed thickness, giving rise to ectasia, and a large amount of regression as well. So the current trend, friends, is to limit our corneal laser surgeries to -8 or -9 diopters. And beyond that, what we use now is phakic lenses. Phakic lenses are basically artificial lenses. They're implanted in the posterior chamber now. They used to be implanted also in the anterior chamber in the past in presence of your natural crystalline lens. This is a study that our group had actually published in early 2000s, in which we had actually showcased that if one eye undergoes LASIK and one eye undergoes ICL for almost -10 diopters, then at the end of 10 years, the LASIK eye actually regressed to -2, and this ICLI was still at 0.25 to 0.5, demonstrating a better amount of stability with ICL in those patients. So anybody who has more than 8 diopters of myopic equivalent today, or the patients who have thin cornea or very large amount of or very severe dry eye where you cannot do corneal laser surgery, and if the anterior chamber depth is 2.8 millimeter or beyond, then the phakic lens implant is the current solution. There are a variety of phakic lens implants which are available today. I've had experience of using all of them, but of course, large majority of my patients undergo what is called as the star ICL. For the benefit of the postgraduates, I'll just showcase how a procedure is performed. As you can see, I'm making a small, I'm making a small paracentesis. So once we have created 2 paracentesis, I'm using intracameral lignocaine, and I'm using viscoelastic, entering with a 3.2 millimeter keratome and marking the cornea because this is a toric ICL. Once the cornea is marked, then we go ahead and actually implant the lens. This is the ICL, which is only 100 micron in its thickness. It's very, very delicate. You have to actually handle it with a lot of care. These 2 marks, friends, that you can see there for alignment for your toric marking. It has 2 foot plates, which has to be put behind the iris. It's a very quick procedure. As you can see, barely takes 3 to 3.5 minutes in my hands. And once the lens is quite well in its place, you have to make sure that you remove the viscoelastic very well. Now, these lenses come with central hole. Therefore, you don't have to do any peripheral iridectomy, which was required before to avoid the chances of pupillary block. And once this is done, you just plainly, let's say, hydrate your side ports and the main port, and then you're done with the procedure. The ICL has been my first prototype that I use definitely, but I have had experience of using the other ones also, just showcasing the how the other ones are loaded. The other lenses are loaded more like IOLs, but the ICL has a completely different loading pattern. I'm not going into the details of that because this lecture is mainly for postgraduates and very, very young ophthalmologists. But when it comes to that, ours is the Western India's Center for Star ICL training. So if any of you would like to get trained in the future, of course, you are most welcome. So these are all the 4 lenses which are being implanted. You can see that when they are being implanted, the other manipulations and other things are almost similar. The other lenses are slightly thicker, slightly more stiffer as compared to the ICL. So the phakic lenses, why they are treated for very high range of this myopia, are basically because it retains much better visual quality, but it has other advantages. It has less amount of regression, does not induce any dry eye. They are removable and exchangeable, and importantly, they retain your crystalline lens as against lens exchange surgeries, so that you preserve accommodation and very good near vision as well. And of course, it improves in many of the patients. Even in my hands, I have seen that that patients see actually much better post-operatively uncorrected than they used to see pre-operatively with the glasses, because you have eliminated the magnification effect of the glasses itself. Of course, it has its own risks because it's an intraocular procedure. There is a minute risk or very rare risk of endophthalmitis. But there are other possible complications such as endothelial cell loss, possibility of formation of cataract and glaucoma, which is being seen with the current generation of lenses seen in 1 in 2 to 4,000 eyes. The current indications, as we have discussed, is that you need to have stable refraction. I personally do it for patients who are LASIK rejects, which are myopia beyond 8 or 10 diopters, hyperopia more than 6, if the anterior chamber depth is more than 3 millimeters in those cases. If the corneal thickness doesn't allow us because of very thin cornea, or if the expected residual bed thickness is going to be less than 280 microns. If you already have a very, very flat cornea, you don't want to induce a lot of aberrations when you are doing laser, or if you have a patient who has significant dry eye, or a patient who has either keratoconus suspect or stable keratoconus patient after cross-linking, these are the patients who are the best patients for phakic lenses. You should avoid phakic lenses for patients who have low endothelial cell count, low anterior chamber depth, of course, any active other disorder in the eye, and progressive keratoconus. In progressive keratoconus, you have to stop the keratoconus with cross-linking. And if the patient's visual quality and the quantity is significantly good with glasses, you can go ahead with phakic lenses as well. So the journey still continues because now there is a resurgence of advanced surface ablations with newer generation of lasers. There are newer developments of new designs of phakic lenses, including EDOF phakic lenses, which have come now. There are new generation of presbyopic treatments. There are acceptance of also bioptics for very large metropias. The SMILE is also coming for hyperopia, which is not currently possible. And there has been some promise in with only cross-linking, control cross-linking treatment as refractive surgery, very early results up to -2 diopters. And who knows, maybe in the future, you may have also gene therapy to take care of refractive corrections. So all my journey, I'm very, very thankful to my mentor, Professor Phakic, who is the reason of all my success and all my, let's say, learnings in refractive surgery. And of course, I always end with the quote by Thomas Edison, there is always better way to do it, and we have to find it. And friends, although this is probably not the forum, but because we are coming very close, just a small request. If you find that I'm worthy, please support me for member scientific committee in forthcoming AS elections. And I think whenever we are ready, we will go to the questions for your quiz. Thank you so much. Thanks again to Dr. Harshul and Dr. Vishal for very kind invite. It is always such a pleasure to come back to ROS. Thank you. Thank you so much.
Thank you so much, Dr. Vardhaman, for that very comprehensive talk on covering each and everything about refractive surgery, from LASIK to the phakic lenses which we are using nowadays. So I think first, let's take some questions from whatever PGs want to ask. So I'll request all our residents and younger surgeons to turn on their video, and whomsoever wants to ask any question, we do want that you should ask question because this is the time for you to learn, to ask questions. So can you all please turn on your videos so that I request all of you to turn on your videos, please. Yes. So I think Dr. Ayushi Verma asked one question. Ayushi, unmute and please go ahead. Ask your question.
Yes, sir. I have two questions. One which sir explained in photo.
Please, Ayushi, please introduce yourself and where you are like training and all those before you ask question. Yeah. Yes.
Good evening, sir. I'm a third-year resident in SMS Medical College. And my question is for you, sir, that in photorefractive keratectomy, you mentioned regression is occurring. So I wanted to ask about that. And second question is, sir, in LASIK surgery, we have one superior flap and nasal flap. So which one is better and why, sir?
Okay, sure. So I'll come to the first question. Actually, in PRK of the previous generations, the PRK was done actually with different kind of lasers also, because the lasers were what are called as broad beam lasers. And there was no use of mitomycin C also. So in those times, there was a lot of haze. And whenever there is a lot of haze, it also brings in a lot of regression. So the regression of those times is slightly different than the regression we see now sometimes, but the regression now has become reduced because we are also limiting our ablation. In those times, again, for PRK, there was no limit. People used to go to 8, 9, 10 diopters or even more. And along with that, using broad beam laser and using no mitomycin C led to a lot of regression in those times. Okay. So why you get haze in those patients? Basically because the anterior stroma has a lot of active keratocytes. So these keratocytes are known to get transformed into very active keratocytes. These active keratocytes are known to actually, let's say, formulate a lot of newer but irregular collagen fiber and extra this metallo matrix proteinases. So basically, all this irregular structure of the connective tissue which is forming gives rise to haze. So in those times, the haze was common because of these three reasons. Now the haze has reduced a lot because we have first limited the ablation. Now we don't go beyond -6. Number two, we are using mitomycin C, so that has reduced the scarring and haze. And number three, of course, is that we are actually using lasers, which are much more superior now. They do not cause a lot of thermal loading. Thermal loading means that there is, whenever the pulses are there, these are all flying spot technology. So when a laser pulse goes, the other pulse will come there only after some time. Therefore, there is no thermal loading on the cornea. Now I'll come to this current generation lasers also sometimes can showcase regression, but that regression now is slightly different because that regression can be because of mild haze sometime, but it is mainly because of the epithelial hypertrophy. Because there is a long-term flattening, sometimes the epithelium is known to compensate for that. So it's slightly different what used to happen in the past in early 2000s, and it's slightly different what happens today. Coming to your other question, which is basically the superior and the when it comes to the hinge location and the nasal location, frankly, there was a lot of research which was being done, and there was presumption that from 3 and 9 o'clock, you have more corneal nerves which come. So if you preserve it when you're creating a nasal hinge, you're preserving more nerves. So dry eye might be lesser rather than superior. So that was the advantage which was seen with the nasal. And the advantage which was seen with the superior was that the flap displacement was lesser, basically because the hinge is superior, and because of the blinking response, the flap was always kept in place. Frankly speaking, there have been a lot of studies now. There have been Cochrane review and meta-analysis which has shown there is no advantage over one over the other. But right now, we all prefer superior hinge when it comes to the femtosecond lasers. Okay, but when it comes to mechanical microkeradomes, still the nasal hinge are more in vogue because the current generation of mechanical microkeradomes make more easily nasal flaps than superior flaps. But reality, there is theoretically some benefits were presumed, but nothing is proven now. Yeah.
Okay, so here I'd like to ask all the residents one question, that as we are discussing that nowadays what we call advanced surface ablation, right? So in this we use mitomycin C to prevent formation of haze. Can anybody tell me what is the concentration of mitomycin is used and how it is used in PRK? Anybody?
Sir, 0.02%.
Can you unmute and no, you are of course unmuted, but can you just turn on your video? I think it's Mukesh Kumar. Mukesh,
Yes,
yeah, tell me.
sir, we use for 1 to 2 minutes.
1 to 2 minutes.
Yes, sir.
Anybody
And
else?
27 seconds to 1 to 2 minutes.
Anybody else?
Sir, 12 seconds, sir.
Okay. Vardhaman, can you tell them, please?
Yeah. So I think we use now 0.02% for up to 12 seconds generally. But for every diopter that we go beyond 3 diopters, we increase it by about 10 seconds. So, and if there is what is called as enhancement means that you have undergone LASIK in the past and you want to do PRK as touch-up laser, then you keep it for 30 seconds to 1 minute's time. But generally 12 seconds is the answer that you should give in your postgraduate exams. Yeah.
Yeah. And there is another concentration which is used, that is low dose mitomycin C, 0.002%.
Yeah.
So so that we use for 2 minutes.
Yeah.
So studies have shown that for lower diopters, both are equally efficacious. But for higher diopters, 0.2% one is better than lower concentration. Yeah. Okay. So Shaghi Khan wants to ask something. Yes. Shaghi?
Yes, sir.
Yes.
Sir, I am a consultant ophthalmologist at Sharpsight Eye Hospital. I do mainly phaco surgeries, but I'm interested in LASIK. Sir, I have a question that how precise is LASIK extra? That is C3R plus LASIK. But and what are the indication of LASIK extra?
Okay.
And sir, another question, sir. I would like to go into this refractive surgery training, and as I'm working, I cannot go like for 2 years or 18 months training. So what are my options? I know this is not the forum, but I would like to
No,
know.
of course you can ask.
Please
Of
guide
course,
me.
you are at the right place.
Yes.
Shagil,
Yes, sir.
Vardhaman?
Yes, Dr. Shagil. So basically, number one is you asked about extra procedures. So extra procedures are whenever cross-linking is combined with the corneal laser, they're called as extra procedures. You can combine it with PRK, called as PRK extra. You can combine it with LASIK, called as LASIK extra. You can combine it with SMILE, called as SMILE extra. But frankly speaking, whenever you are making a cut, either with LASIK or SMILE, you are actually biomechanically weakening the cornea. So the extra the concept of extra with LASIK is actually not well accepted in the scientific community all over the world. Okay. So currently the only extra which is really accepted is the PRK extra when it comes to the eyes which are having slightly thinner or slightly questionable topographies. Now I'll come to only one indication of LASIK extra, which is accepted around the world, is for hyperopic treatment, because some studies have actually shown that your regression rate can be lower with LASIK extra if you are actually doing it for hyperopia. Frankly speaking, there is only, let's say, when it comes to real proof of this in terms of publication, there are only a couple of centers. One is in Japan and one is in Athens who have actually shown this. But frankly speaking, not something that you would like to indulge in early career. I think you have to be very selective in choosing these procedures. Yeah. And now coming to the other aspect in which if you want to learn refractive surgery. So basically, there are some centers which give short-term refractive surgical training. We are one of them. So we give a week or 2 weeks time refractive surgical customized training for basic surgeries such as surface ablations and basic LASIK surgery for that short time. Of course, I do believe that if somebody wants to really become a proper refractive surgeon, you have to spend 1 to 2 years to in this field with some experts. But if you want to just start by doing some patients occasionally, then definitely that is good enough for you to have a starting point. So I think we can give it. And then there are, I think, Dr. Rupal Shah, madam, she gives it in Vadodara.
Yes.
There are some other centers also who give it. Yeah, sure.
Yeah,
Thank
so I think what Dr. Rupal also giving Dr. Vardhaman is 2-3 days or 4 days of training. So they give all didactic lectures and videos and everything. Then they give 2 or 4 eyes
Yes.
on to operate on.
Yes, sir. Yes, I have contacted them, sir.
Yes. So you can contact Dr. Vardhaman. Yeah, they are also giving it, right?
Sure, sir.
Yeah.
Thank you.
Yes. Any other questions from residents? Okay. So I think let's take 2 of the quiz questions, Dr.
Yes.
Vardhaman.
Yes.
So whosoever writes first in the chat box will be given the prize for this. So first question is?
So first question is mechanism of femtosecond laser is photocoagulation, photoablation, photodisruption, or photothermal effect?
I think the earliest what I can see is Ayushi Verma to everyone, 8:25 p.m. C.
Okay. Good.
Photo disruption.
Congratulations. You have given the right answer.
Okay. So Dr. Ayushi is the first winner. And second question, just a minute, let me check. Yes, please go ahead.
Okay. The second question is the process responsible for keeping the flap in its place after the LASIK surgery is endothelial pump activity, corneal scarring, corneal epithelialization, flap position, and shape.
Okay. So Dr. Pushkar Raj. No, I think Darshana Pariyar has given first answer. A. Can you see, Dr. Vardhaman? Can you also see?
I don't know.
Chat box.
Is it, 1 second. Let me check.
In your chat box,
I think
I can see is Darshana Pariyar.
Darshana Parihar. Correct.
Yes.
That's
okay.
right. 25. Yes, that's right.
Okay, so these two are the winners of today's quiz. And let me give you one more question. One more prize, extra prize. Okay, C already has come. No. So, because it was not planned, so we don't have in the system. But I would like that whosoever raise hand first will get the chance to answer. I can see. Vardhaman, you also take care. Who is the first to answer? So, in ICL, there is a central hole. Can anybody tell me the size of that central hole? Who is there? Asking Google. Mukesh. Try. Okay. Nobody. So the prize remains with me. Huh? So the size of that hole is 360 micron. Okay. Right. So any other questions from the resident? Okay. So I think with this we come to end of this Kaksha series, and it was really wonderful to have Dr. Vardhaman Kankariya, who took amazing Kaksha class on refractive surgery, the journey of refractive surgery and various refractive procedures which are being done today. Thank you very much, Dr. Vardhaman, for sparing your time and being here with all our residents. And see you soon and again in another Kaksha series.
Absolutely. Right. Thank you. Thank you so much again, Dr. Harshul and Dr. Vishal and whole ROS. Thank you. Always a pleasure.
Thank you. Thank you so much. Bye-bye.
Bye.
Bye. Good night.